Dr. Scott Regenbogen for talking to OnSurge today about changing management of acute diverticulitis.
Hi, thanks for having me.
So what has changed in the last 10 to 20 years in the management of diverticulitis, particularly acute diverticulitis?
Well, I think for acute diverticulitis, historically, the presumption was that any patient who had a perforation was going to need an emergency operation, and that emergency operation was going to end in a colostomy. And that was fairly standard. The Hartmann procedure was used widely, and as a result, you had a lot of patients with colostomies that became permanent. Many of those patients would never be good candidates for closure. It was a big operation and a complicated operation to get them closed. And there was a lot of morbidity associated with that operation. Yeah. And if you ask, well, why was that operation done so frequently, I think it had a lot to do probably with the relative lack of good antibiotics, the lack of good intensive care, the relatively limited options for percutaneous drainage of abscesses, all of these modalities that we make extensive use of today. And I think the idea that free air mandates a laparotomy has really become only a half-truth. There are certainly patients with sepsis and free air who need an operation, but many patients can be managed with antibiotics and drainage. So that's given us lots of options we didn't used to have.
Right. So emerging technologies, new antibiotics. How about data supporting this change in management?
Relatively limited because it's so hard to really, I think, quantify how sick patients are. There's so much clinical judgment here. But if you look at simply the rates of use of Hartmann procedure, that's clearly gone down. If you look at the population-based rates of emergency surgery for diverticulitis, those have not increased despite the decreased use of elective surgery for diverticulitis, which would tell you that at least we're not ending up with so many more patients with acute diverticulitis. But as far as real data to support the treatment of acute diverticulitis, it's relatively limited. There are some imaging-based predictors, specifically something called the Ambrosetti scale, which looks at characteristics of a CAT scan that might predict the need for an emergency operation, things like size of the abscess, location of the abscess, pelvic versus abdominal, whether there's diffuse free air. And those will predict behavior of a surgeon, but that doesn't necessarily tell you what the best thing for the surgeon to do would have been. I think what's really happened is people are using good clinical judgment to try to decide which patients need emergency surgery and which ones don't. And as a result, what you're seeing is a lot of use of percutaneous techniques and really just watch and wait and allowing patients to declare whether they're going to need an operation or can get better without one.
Yeah. So the old dogma has sort of disappeared and it's managed much more on a case-by-case basis. Yeah.
I think that's right, which is obviously challenging. It means if you take away a rule-based principle and replace it with judgment, it asks a lot of surgeons. But I think
asks us to think.
Correct. But I think as a result, a lot of patients are being cared for a lot more efficiently, and probably with a lot less morbidity.
Sure, a lot of them with much less invasive procedures. Can you talk a bit about non-operative management and drainage procedures that are in common use now?
Yeah, so I think so in my hands, basically the only operation for going straight to the emergency room to do a Hartmann procedure is a patient who's septic, and even then, but to get more to your question, so I think if a patient has a contained abscess that is amenable to percutaneous drainage, I think that is often successful. Many of them will end up with a cholecutaneous fistula that may need to be dealt with surgically down the road. But percutaneous drainage with either CT or ultrasound guidance can really get a lot of those patients through the acute episode. And then there is emerging, there have been several recent papers looking at the ultimate outcome of those patients. So what happens to patients who get percutaneous drainage and whether they go on to have operations. And I think these studies would say that about a quarter of patients who get percutaneous drainage will never need an operation and will do fine. The rest of them will go on to have operations, whether they needed them or not, but will go on to have operations. But there's patients who make good clinical decisions, both acutely and then in subacutely, they can keep their colon and not need an operation.
Yeah. And so what operation are you doing when you do, describe the patient to me who has pretty hard indications for surgery and and what operation you typically do.
Right. So I think a patient who's going to go to the operating room in an acute setting, almost no matter what, is a patient with diffuse peritonitis, with sepsis, hypotension, fever, an elevated white blood cell count, clearly looking ill in the emergency room. I think the old adage that a surgical belly needs an operation, I think, hasn't changed. And for that patient, I think that in my hands, the most common operation would be a low anterior resection, either with ideally a colorectal anastomosis and diverting loop ileostomy, or if the patient really is too sick to even tolerate an anastomosis, then I think a Hartmann procedure still has its role. There is certainly increasing discussion, and to some lesser extent, increasing use of laparoscopic lavage as a modality for acute diverticulitis. The principle being maybe we can just wash out the belly, either put some stitches over the hole or put some momentum over the hole, fix it like a duodenal perforation, and get patients through the acute episode without an operation that requires a stoma. I have not personally used this operation. I feel like at the moment the data supporting this operation are still mostly anecdotal. There are several trials going on in Europe, and we'll await the results of those.
Okay. Yeah, and you're talking about lavage as the treatment as opposed to colon lavage, the on-table lavage that for a while had a popular run.
Correct. Yeah, I'm talking about laparoscopic lavage, simply cleaning out the peritoneum. And I think the trouble with the trials, reported retrospective trials of laparoscopic lavage so far, the real questions about these have been patient selection. So I think careful observers of these studies have asked whether the patients selected for those trials were really patients that could have been managed without an operation at all. And so the fact that they did well with laparoscopic lavage doesn't necessarily tell you what they would have done if they just had percutaneous drainage and some antibiotics.
Okay, great. So what else does a practicing general surgeon need to know about changing management, and last words on management of acute diverticulitis?
Yeah, I think the real thing to know is that you have choices, that you can make good clinical decisions, that the full spectrum of therapies are certainly acceptable as long as they're done in the right patient. So my principles that I try to follow are, operate when a patient needs an operation, but don't operate if they don't need one. Obviously, that's a little pithy and hard to follow. And I try real hard not to do the Hartmann procedure unless I absolutely feel backed into a corner, because I know that second operation, if I have a diverting loop ileostomy, is going to be so much less morbid than a colostomy closure.
Yeah, well, that's great insight. Appreciate it. Thanks for talking to us today. Hope to talk again soon.
Thank you.
Bye-bye. Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook, follow us on Twitter, and find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.